can go ahead and get started. We welcome you through today's presentation, and we're excited to share the mic with a presenter today. So we will get started with some welcoming remarks. Thank you again for joining us. Some of you participated in our kickoff meeting that occurred on April 20th. If you didn't get a chance to participate live, just friendly reminder that the recording and meeting is posted via our Confluence site. And today we are very excited to hear from one of our participants, Cody. You get to hear a little bit more about them. Due to the large number of attendees, everyone has been muted upon entry. This call is being recorded and will be posted within 2 business days. We are encouraging your participation throughout today's meeting. Feel free to say hello via the chat, ask questions. If you would like to speak or raise a comment, thoughts, you can use the reaction function, the raise hand, and we'll be able to get to you. Everyone's welcome to send all the chats to everyone so we can ensure that we don't miss any messages. If you have any technical difficulties, if Zoom is kicking you out, if there's any issues, please contact our team member, Savannah. She'll be able to help you behind the scenes. For today, here's our agenda. So we'll start off by setting the stage and then really diving into, for about half of our call, to the Clinical Community Data Initiative presentation in collaboration with the Colorado Health Observation Regional Data Service, also known as CORDS. And we really hope that to be an interactive discussion. So we welcome people to ask questions via the chat, and they will be addressed towards the end of the presentation. And we will review some of the feedback on the proposed business case and review our consensus voting process and allow time for questions and homework review at the end. And now I would love to hand over the virtual mic to Kyla.
Thanks, Gabriella, and thank you everyone for coming to our work group meeting number 2. I am Kyla Davis, and I am in the Office of Informatics and Information Resource Management in the National Center for Chronic Disease Control and Prevention that we call NCCDPHP. Now, our center really works to prevent chronic disease and promote health across all ages. So we're really looking at where people live, learn, work, and play, that saying around SDOH, to improve health across the entire lifespan. And so for those who are actually unable to attend the kickoff meeting, I do encourage you to listen to the recording, as Gabriella mentioned, to hear more about our center, but really to hear about our center director talk about why NCDPHP is uniquely positioned to lead this public health SDOH use case initiative. But before we get into the agenda today, we really wanted to take a minute to talk about several drivers that will shape how we move this initiative forward. And so next slide, please. Oh, Gabriella, can you still hear me? Because for me, it just froze. I know.
Yeah, I was just saying, yes, we are on the next slide. You froze on my end as well.
Okay, I'll speak to it. I do apologize for that. But what we really wanted to highlight here, there are 3 core drivers for our initiative. And it really stems from the HHS strategic plan, action plan that they're developing. So HHS is developing an SDOH action plan. It's really challenging the agencies like CDC to provide steps in addressing the core data SDOH challenges. And we did talk about some of our SDOH data challenges in the first work group meeting. So again, I encourage you to look at the recording. But what is this resulting in is that we really need to understand the SDOH ecosystem at all levels. As you can see in the picture, we are looking at the community to individual impact, upstream and downstream needs, what approaches work, really looking at what approaches work in the community, and how we can really accelerate getting this data to help drive the HHS objectives. And I know some of you might be thinking, was this SDOH action plan that is still in the making? We did provide a resource that has the overall strategic approach, but once we do have that action plan, we will share with this team. So what does that mean? We really need to start really understanding our core public health SDOH challenges. As I mentioned, we kind of like talked about this at the kickoff meeting, but we want to continue having that discussion throughout the work group. But then we also need to understand the current state across our partners. And we're going to get through that today, highlight some of that today through the CODI project that Dr. Emily Bacon is going to talk about. So we really envision that these work group meetings will help us get to those goals, and it will really produce a framework that can be repeated across other conditions and diseases. I know this initiative is really going to be focused on chronic disease, but we also going to be intentional to make sure that it's going to be a repeatable framework. So with that, I thank you for your participation, and we're really excited to address these challenges with you. Thank you.
Thank you, Kyla, for setting the stage for us today. And we really encourage you to get familiar with the Confluence workgroup page, as it houses and stores all of our materials for easy access. So the latest information will be posted there. And continuing with sort of our workgroup participation and some of an overview of what it means to be part of the work group. So as mentioned, you can find our kickoff materials. If you have not done so, we encourage you to officially join the work group as a member. If you are not sure if you have signed up, feel free to reach out, or you can actually check on Confluence whether you have signed up or any other members or team or colleagues from your organization have registered. We are using Confluence because it is an open, transparent platform and is easy to manage, especially with a large and cross-sector stakeholder group. So, and if you see yourself twice, we were cleaning out duplicates earlier this week, so hopefully we have that all sorted out, but no worries, we double check that every week, so we will ensure that we have your latest information there. And then if there are specific questions or anything that you are not able to find on Confluence, please don't hesitate to reach out. Myself, Gabriela, Savannah, and Kyla are the point of contacts for the work group. To give you our holistic overview of every meeting, we are convening for 90 minutes every other week for a total of 8 sessions. So as you can see here, we are on session number 2. And we have, a wonderful agenda for all of you today. Just highlighting the rest of our schedule. So honing in into what are our objectives for today. All participants today will learn how public health agencies are leveraging individual level social determinants of health data collected at clinical or community-based settings through an example of the Clinical and Community Data Initiative, also known as CODI, in partnership with Colorado Health Observation Regional Data Service, also known as CORDS. That will be the first half of our meeting, and then we'll segue into capturing and reviewing the feedback received on the proposed business case. And we will then segue into an overview of the consensus voting. We understand that this might be, for some of you, first time joining an open collaborative. So hopefully our presentation today will aim to support your understanding of the process and have an opportunity to ask questions live as well. So without further ado, I will let Kyla introduce our guest speaker today.
Thanks, Gabriella. So today we will be having Dr. Emily Bacon. We're really excited, and she's going to really be touching on, as I mentioned earlier, really what partners are currently doing. And so Dr. Bacon has over 8 years of experience working with EHR-based chronic disease surveillance systems. Her background is in health inequity, mixed methods research, and health informatics. She received her doctoral degree from the University of Colorado Boulder in sociology and population studies. Dr. Bacon has worked in various capacities in CORDS, which Gabrielle mentioned, which is a distributed health data network in Colorado, as well as the CODI project. And we've talked about CODI a few times on this call already. So we're really excited at the fact that she'll be coming here to like deep dive into that CODI project, which really focuses on community clinical linkages. Dr. Bacon has led the evaluation of the CORDS network in 2018, and she has published manuscripts and reports describing the CORDS infrastructure, population coverage, record linkage, and social determinants of health data architecture. She designed programs to create survey weights, coverage estimates, and data quality assessments tools for the CORDS network. And she has supported the CODI project in executing privacy-preserving record linkage and incorporating social determinants of health data in the CORDS data model. So as I mentioned, we're really excited to hear more from Dr. Bacon. And with that, I will hand it over to her.
Great. Thank you so much, Kyla, for such a kind introduction. And it's great to be with you all today. So I'm going to be talking about our experiences with SDOH data in the context of a clinical community partnership in Colorado. But before I begin, I know that this work requires a huge amount of collaboration and effort. And so I want to acknowledge the many people and organizations that have made it possible and the really diverse skill sets that it involves. That includes programmers and project managers and even, executive directors of CBOs who've learned how to run Python scripts, and the many leaders who've championed this work. Some of those folks are on the call today, and if you are, please feel free to augment anything I'm saying or give more details in the chat if you feel so inclined. Many folks are not on the call, and I want to acknowledge all of the work that they've done. So I am one spokesperson of many that could give this presentation, and I'm truly honored to be with you all today. Next slide, please. So I'm going to take you through a lot of information. I'm a pretty fast talker, but I wanted to share up front that because we wanted to make this presentation as comprehensive as possible, there are quite a few slides, and some of them have a lot of information in them. Since all of this will be posted, you can go and look at some of these slides in more detail. There are some that I'm just going to summarize and others that I might talk about in more depth. But I'm going to give sort of, I think, the whole presentation, and as questions come up, please put them in the chat. And then at the end, we can go through and address them and go back and look at slides if necessary. Okay, so, sorry, I'm going to have to go back. Sorry, I just want to talk about a brief overview of what we're going to be talking about today. So I'm going to give an introduction to sort of how we think about clinical and community partnerships overall. And then I'm going to dive into local implementation and really talk about what the CORDS network and the CODI project have done and what we plan to do. I'll talk about our experiences and challenges, standardizing and sharing SDOH data between healthcare systems and community partners, and then also end by talking about opportunities and future directions for this work. Okay, next slide, please. So when we think about sharing SDOH data between clinical and community partners, it's important first to define what we mean by SDOH. And as Kyla mentioned earlier, CDC has a really broad definition of SDOH as the conditions in the places where people live, learn, work, and play that affect a wide range of health and quality of life risks and outcomes. And in our clinical community partnership, we also take a really broad approach to defining SDOH. As Dr. Hacker and others mentioned in the last workgroup meeting, we want to understand the ways in which social factors impact an individual's health, but we really also want to be able to assess the health of communities as their own important entities. So clinical community partnerships are essential to understand this full scope. As this figure shows, individuals move through clinical and community spaces. Their experience in different organizations can be evaluated holistically, but they can also be evaluated iteratively as they move back and forth and back and forth. And importantly, they can be evaluated longitudinally over time to see how the impacts of different organizations, the impact that they have on individuals over a kind of a longer span than sometimes we look at. So importantly, these data can be assessed in a timely fashion because often they rely on data that organizations use for other purposes. So in the clinical world, we often use electronic health records as our main data input. And in the CBO world, we might use records like attendance records or phone logs, things that organizations are already using for their daily workflow. And this presents a huge opportunity as far as timely data and important data. But as you can imagine, it also presents a huge challenge, because as we integrate these data to have important public health use cases, we have to realize that they were not designed for that purpose. So we have to think really critically about how we use these data and what they can and cannot tell us. So this work to create clinical community data systems is incredibly exciting, but it's also incredibly challenging. Next slide, please. Okay, so I'm going to talk through what SDOH data collection and integration looks like from a health systems perspective, and then from a community organization perspective, and then sort of integrating them together. So from a health systems perspective, a typical approach to SDOH would be to collect, track, and evaluate SDOH data to address the social needs of individual patients. And this is often done through questionnaires or screeners around social needs. There are a lot of opportunities to build on SDOH within health systems. As many of you know from your participation in HL7, the Gravity Project, we can build on standard metrics within EHRs like diagnosis codes and systems that are already being used, and enhance them by allowing them to incorporate new kinds of SDOH data. But health systems are also exploring a lot of other opportunities in the area of SDOH. Some of you might be involved in health systems that address social needs directly, like by providing food services or transportation services to patients, or through partnerships and referrals. So health systems often try to think about how they can collaborate with organizations in the community that are doing important work and document their referrals to those organizations. So there's a lot of opportunities for SDOH work within health systems. And of course, I'm just mentioning a few. Now, there are some major challenges. As this work group has already discussed, adopting the standard metrics is complicated. SDOH language can vary a lot across organizations. And we know that a lot of times health systems don't implement universal screening. So one of the health systems I work with, they try to universally screen pediatric patients and high-risk patients. But that leaves out a big cohort of patients. So when we think about public health integration and how we can use this to understand the entire population, we have to know who's being screened and work towards trying to get universal screening so that we have more opportunities for different kinds of public health use cases. Next slide, please. So then in the context of community-based organizations, often these organizations approach SDOH by facilitating the delivery of services to meet social needs. And so these organizations provide not only information about individuals, but also information about households and communities, which is often unique from what we see from a clinical perspective. And there are also just so many opportunities for how we can think about SDOH data in community-based organizations. Often we use cross-sectional data and social surveys, and we rely on those for a lot of our public health use cases, but these only give us a snapshot. And clinical community partnerships offer more than just a snapshot. So if you're a child who has obesity and participates in an after-school running program, just knowing that you attend doesn't help us very much. But CBOs can start to give us data about client-level longitudinal participation. How often is that kiddo going to that program? And is it really working? And so then we also can start to look at not just what's happening to a client or a patient over time, but how a particular program might impact a certain group or community. And then really start to think about community-level information on social needs and disparities. Now, like healthcare organizations, there are lots of challenges that we face when we're integrating and collecting these SDOH data from CBOs. Not many CBOs do primary data collection, so they're not often screening their patients for social needs. Some are, but oftentimes we gather SDOH data in different ways. The data extraction process for analytics and integration can be really complicated. We oftentimes have standards that we use that we need for data collection and integration. So sometimes we have to help community partners kind of align with those standards. And that requires a lot of technical assistance. So some CBOs, particularly small ones, they may not have a lot of staff that have experience doing certain kinds of technical activities. So being able to provide them technical assistance is really important. And then again, there's limited uniformity. So we might want to partner with lots of different community-based organizations that are doing lots of different things, and they're going to have data systems that work really well for them perhaps, but may not be the same. So thinking about how we deal with that limited uniformity to really be able to standardize the data in a way that's meaningful for public health is an ongoing challenge. Next slide, please. So that's sort of health systems and CBOs separately, but then we think about clinical and community interoperability, and we have even more data problems to address. So these are often disparate data and systems. Now, the CORDS network started just as healthcare organizations, and we only onboarded healthcare organizations that had electronic health records. So we could kind of live in this EHR world. But as we bring CBOs on board, we have to think about a totally new kind of data that we're working with now, which makes us rethink not only our tables and our technical systems, but also our governance. And so that's really, really something that this interoperability makes us think more about. We have to create the infrastructure for linked longitudinal data across programs, settings, and systems. So this requires having partners function in maybe different ways than they had before, partners taking on leadership roles to house and integrate those data, and then thinking about the technical components of this infrastructure really carefully. And then of course, the privacy and security is a big part of this work. We really want to make sure that the work that we do is keeping patient privacy or client privacy as an utmost tenet of importance. And this is, again, not only important because we want to make sure that our systems are private and secure, but it's really important for generating trust across really diverse sets of partners. And from community-based organizations that may not participate in a lot of other data sharing groups, we want to make sure that they feel really secure that their client information is being used appropriately and securely. Okay, so now I'm going to talk a little bit about our specific implementation of this community clinical community partnership. So the CODI project stands for the Clinical and Community Data Initiative. And the aim of CODI is to bring different types of data and organizations together to support public health surveillance, planning and evaluation, health services research, and comparative effectiveness research. The data sources include distributed healthcare, intervention, social determinants of health, CBO, and administrative data, pulling it all together. And then the goal is to facilitate the development of this individual and household level linked longitudinal clinical and community data. So it's a big effort, lofty goals, and we started doing it. So it's really exciting. This slide provides some examples of different kinds of data, but I just also want to mention that we know that individuals touch many organizations across a community from where information is captured. So we want to try to figure out how to bring these data together across space and time at the individual level to create this kind of single record. And then also something that CODI has on the horizon is doing household level record linkage to be able to look at households and how they move through clinical and community spaces as well. So one of the key tenets of CODI is not to reinvent the wheel. So rather than recreating or designing specific tools, CODI really tries to leverage and enhance existing open source information technology. Okay, next slide, please. So CODI is a national collaborative, again, with local implementation. So here's a list of some of the CODI partners. We have many, so this is just a snapshot, but this gives you a sense of the scope. We have members that are clinicians, informaticists, program managers, public health staff, and in Colorado, the CODI pilot, which sort of was the beginning of CODI, has really focused on pediatric weight management. So the population and the data that we are working with right now is really focused on kids aged 2 to 19 and programs related to childhood obesity, food insecurity, and weight management. But CODI has much broader goals. And so we are expanding to include adults and other kinds of health outcomes beyond obesity. But some of the data and the experiences that I'm going to talk about involve sort of the pediatric population in the context of weight management. Next slide, please. So one of the great opportunities and one of the reasons why Colorado was selected to implement the CODI pilot was because of the CORDS network. So CORDS stands for the Colorado Health Observation Regional Data Service. And CORDS is a distributed health data network that began more than a decade ago. It's grown to now include 14 healthcare providers, including 3 behavioral health providers, and thanks to CODI, some new community-based organizations. The primary data users for CORDS are public health agencies serving Colorado's Front Range and also researchers. So CORDS covers approximately 40% of all children, it contains 40% of all children and 25% of all adults in the Metro Denver region. It's a big data set, but it is centralized in that sort of Denver area. And so the data have been used for a lot of different purposes. Public health agencies use CORDS data for their community health assessments, projects around specific conditions like obesity monitoring or prevention, and a lot of COVID-related work, as you can imagine. So the goal of CORDS is to expand the use of EHRs to be able to provide timely public health uses. And so CORDS uses a federated model. So the data partners implement a common data model to their own virtual data warehouse rather than having a centralized data repository. And then queries are executed using a data mart client called PopMedNet, which is an open source tool from Harvard Pilgrim. So we were able to utilize that existing technology for the CODI implementation as well. Okay, next slide. So now I'm going to talk about some of the specific SDOH tables that CORDS currently has and is designing. So beginning in 2018, CORDS and CODI began building out specific tables to house different types of SDOH data. As I mentioned in the beginning, we wanted to take a really broad approach so that lots of different SDOH data could fit within our data model. Some of the tables have been fully populated and others are still being planned out and executed. But first we have these screening tables. Those are the ones in orange or peach. And those build off of the PCORI data model. They expand on the single patient reported outcomes table to include a couple static tables that describe the patient questionnaires, and then one table that contains response values. So if a patient goes in and gets a screening for social needs, that data would then go into the pro responses table, and we would be able to see information about that screening. CODI expanded the CORDS data model to include direct service tables, which are the program and session tables in blue. And so these are going to capture interventions and specific programs related to SDOH. And these can happen either within a health system or within a community-based organization. So if I go to an after-school running program, I would have that record documented in the program table. And every time I go, say every Monday or whatever, then I would have that logged in the session table so that we can again begin to construct these longitudinal records. The asset delivery table is one that we haven't built out yet, but are very excited about. And this would contain information about the delivery of certain assets like money or food that's given to people and the frequency with which it's given. And then we have a referral table, which we're also building out. And the referral table contains information about outgoing or incoming referrals to different organizations or referrals within the same organization. To other kinds of services. So we can begin to track, again, how individuals are iteratively moving through these different systems within a community. Okay, next slide, please. Okay, so this is one of those really detailed slides that I'm not going to go into a lot of detail on, but what I basically just want to show you is this is a way in which all of these different types of SDOH data that we have and that we're developing in the CORDS data model can be sort of integrated into other components of the data model. So taking different kinds of SDOH data and then resulting in a single SDOH evidence indicator, something that tells you that there are components of SDOH in an individual's record. And this is something we have an excellent postdoctoral fellow working on, but I wanted to share it with you in case you're really interested in some of those details. Okay, next slide, please. So we can't talk about clinical community data partnerships without talking about privacy preserving record linkage. Everybody's favorite topic. So clinical community partnerships are made possible through PPRL. PPRL includes multi-stage encryption and garbling of an individual's personal information so that we're not directly sharing any personal identifiers across organizations. And like I said earlier, it's not only essential to maintain patient privacy, but this is also a key building block of those trusted relationships so that people know that the information on their clients or patients are staying protected. We use an open source solution called a non-link for Cody's PPRL implementation, and we've spent a lot of time tweaking it to make it work for really diverse partners. So one of the challenges when we start to add a lot of different kinds of data partners is figuring out how to tweak, not only from a data quality perspective, but also from an algorithmic perspective to tweak PPRL. To give you a sense, in our current implementation of Cody, we have data partners that are contributing as few as 5,000 records, all the way up to 800,000 records. So that poses challenges in the realms, again, of selecting the appropriate kind of algorithm and making sure that there's adherence to a certain standard of data quality so that we can match individuals appropriately. We are deep in this right now. So if anybody is really excited about this PPRL and has specific questions, I am totally happy to go into this either online or offline later. Okay, next slide, please. Okay, so now I want to share with you some of the kind of specific experiences so that rather than just a broad overview, you're getting a little bit of knowledge about some of the details about what we go through on a day-to-day, which I think sometimes can be informative. So right now, the Cody pilot includes 3 healthcare partners and 2 community-based organizations. The community-based organizations are Girls on the Run, which is an after-school running program for girls, which is a nationwide program and has a lot of participants in Colorado. And then Hunger Free Colorado, which is an organization that provides food-related referrals to a broad group of people. They serve tens of thousands of Coloradans every year, and people can call in and get information about what kinds of food-related services they might qualify for, where they can go to get food assistance, etc. So those are our 2 community-based partners. And then our healthcare partners include a large safety net hospital system, which is Denver Health, and a large HMO, which is Kaiser Permanente, and then Children's Hospital of Colorado and its associated network. And I think that Ray, luckily, is posting some more information too in the chat in case you want to dive in. So for healthcare systems, one of our first steps was to survey partners about what existing SDOH data they were already collecting. And we found that primarily they were collecting information around food and housing. So we decided to focus on those as the SDOH indicators that we really wanted to standardize. We also asked our healthcare partners about whether they were starting to integrate some of the Gravity Project recommendations around diagnosis codes, et cetera, for SDOH, and many of them were. So that's really exciting. Then we had to adapt the data model to all of these different SDOH screeners that were happening across organizations. So some were using standard questionnaires like Prepare, but others were using custom screeners. And so that posed an interesting challenge to try to figure out how we could sort of build in as much detail as possible for these different screeners. And then we also wanted to incorporate health system interventions. So we figured out which healthcare groups were doing interventions around obesity management that we could then include in that kind of program and session tables. For community-based organizations, we conducted an incredibly detailed technical environmental scan to understand which organizations would have the types of data and the tools to be able to partner in this way. But a big part of this wasn't just assessing the sort of technological readiness for participation, but generating trust and enthusiasm to participate. Because I'll talk a little bit later about the importance of symbiotic relationships, but sometimes initially there's not a clear avenue through which organizations can understand their benefit for participating in this network, except for the importance of good public health surveillance. So we wanted to make sure that people were enthusiastic about participating, even if it took us a while to make sure we were reporting data back to them that they could also use for their own purposes. And then the other part is developing a technical partnership. So what we decided to do was have one healthcare organization act as a technical partner for the community-based organizations. And that technical partner housed the community-based organization VDWs. And then they don't house the personal information, but they house the VDWs. And then they can help execute the queries, the data model updates, things like that, so that we're not asking community-based organizations to build out an entire VDW. That would have been very hard. And like I mentioned, we had to figure out ways to create more comprehensive governance around including CBOs into the CORDS network, which included things like expanding the way we think about data sharing agreements and thinking about how we were going to maintain these kinds of partnerships and privacy across, again, a widening group of partners. Okay, next slide, please. So the challenges, always the challenges. So we conducted quality assurance on the health system SDOH data. And so we had to expand our existing QA to really dive into SDOH and what we would expect to see. One of the things that, that we saw was that we had to adjust to health system specific screening tools, as I mentioned before, giving them an opportunity to put customized data into the tables. And then we had to figure out how we were going to capture populations with adequate data over time. For example, something we saw in health systems was that health systems would receive a grant to do social screening from an organization for 1 year. So we'd have a bunch of great SDOH data for a year, and then the grant would end, and that data would just drop off. And so we had to figure out, do we actually have enough data over time and for specific populations to make these data reliable for public health use cases? From a community-based organization perspective, we had from Hunger Free Colorado, they usually collect data at the household level. But for the initial CODI pilot, we're doing all of our linkage at the individual level. So what we found was that if the pediatric patient was directly referred from a healthcare organization, then Hunger Free Colorado had enough personal information about that individual that we could include them in record linkage. So the great thing is that we found a population that we could use, that we could record and link. The downside is that we could have potentially included tens of thousands of people and instead had to limit it just to individuals that we had enough information for. Similarly, Girls on the Run, we use attendance records, but they only captured attendance for like 40 to 50% of their attendees in the early years. And so we had to grapple with what that actually would tell us about participants in their group and whether any of that was sort of systematically collected or whether it was a random collection of attendance. So again, addressing some of these technological limitations has been a challenge. Not all organizations have unique identifiers for their clients. And so making sure we create unique IDs for everybody. Location data was a challenge to record and standardize and geocode. And then we also had to think about missing data across key variables. For example, some organizations don't, like Hunger Free Colorado, it doesn't matter what gender the person calling is, so they don't always collect the gender of the individual who is calling. Other organizations don't collect any data on race and ethnicity, for example. So this, again, is an opportunity where electronic health record data can potentially fill in some of this, but it's also a challenge when we're trying to use some of these variables for record linkage. Okay, next slide, please. So although we had, those are just a handful of some of the very specific challenges that we encountered, we see so many opportunities in this work and are excited about presenting it to you and hearing about what others have also experienced in this realm. There's a huge opportunity for automating processes. So we developed a lot of workflows that we think would work for other groups that we're already working on with the implementation of CODI in North Carolina. Automating processes, making standardization and extraction more easy, and to facilitate this for different kinds of groups. We can do this through sharing technology, different tools that we've developed to use not only record linkage, but others as well, to help people generate data that can be connected more effectively. We really think there's a lot of opportunity in taking advantage of a flexible data model that has a broad definition of SDOH and allows a lot of different kind of data in. It does make our job tricky to think about how we want to, again, produce meaningful data on the back end. There's also a lot of opportunity to collaborate with new types of partners. Colorado is developing a social health information exchange and working with a local HIE on doing this. And then there are a lot of other distributed data networks of other kinds, not necessarily in the health realm, that are great potential partners in this work. So again, a lot of opportunity to build out diverse public health use cases. As we expand to adults, this opportunity is even bigger. And then finding common ground and symbiotic benefits of the data. So along those lines, I want to share just one example with you about how we've given data back to a community-based organization. This is a very rudimentary map. I think we gave them a nicer one, but I just want to show you an example. So on the next slide, you can see, so this was Girls on the Run registrants in Denver County. This is a map of Denver County. And this just shows the distribution of participants by census tract and shows places where a lot of the participants are coming from. And the Girls on the Run didn't have anything, like they had no way of knowing where their participants were coming from before their partnership with CODI. And so this gave us an opportunity to give them some information that was potentially helpful as they think about targeting specific areas of the city, or just generally knowing where their participants are coming from. And I have a little quote here from the executive director of Girls on the Run on the next slide that just describes that process. So it says, we were initially intrigued. This is the Lisa Johnson, the executive director of Girls on the Run. We were initially intrigued when we were approached to participate in CODI, but we didn't quite know where it would lead. Since we joined the project, we received some preliminary insights from our data. We've strengthened connections to community partners in our state, and the CODI team has made participating with a technological turnkey, supporting and guiding us throughout the process. We look forward to continuing to participate as the project continues to evolve here in Colorado. And just as a side note, the Girls on the Run picked up Python scripts really fast. It was like unbelievably amazing to me. I think they'll be teaching me in no time. So it's been really fun work, and I think lots of opportunities here in these kinds of partnerships. Next slide, please. I think I'll just sort of wrap up with some conclusions and next steps. So right now, CORDS has piloted this clinical community partnership across 3 healthcare organizations and 2 community partners. But our next steps are to continue to refine our record linkage process, to onboard new community and healthcare partners to expand to adults, and add some of these new tables that I talked about around asset delivery and referral, to develop reports for community partners so that our relationship can continue to be symbiotic, and then to continue to develop data tools for public health monitoring and research. So with that being said, I've included some links, and I'm like seeing bits and pieces of a chat, so I think there might be some links floating around in the chat. We wrote a broad report about this SDOH data architecture process, and then I also have some links to different manuscripts and websites that might be useful for folks. So with that, I will stop talking so much and turn it over to questions. I might ask Ray, since you've been monitoring the chat, if you want to jump in and talk about any of the particular questions that folks have brought up while I kind of get up to speed. Does that sound okay?
Yes, and let me turn on my camera. Or Gabriella, I don't know if you prefer to do that. If not, I can.
Happy to. Yeah, we were tracking some of the questions that came in. So please, if I miss anything, Ray, feel free to chime in.
Sure.
Okay, so just kind of starting with the first one, Max asked, how are you ingesting data from CBOs and how is it standardized?
Right. So the process of ingesting data really depends on the CBO. So we take their data and we think about how it falls within the SDOH tables that we've built. So if that community-based organization has a specific program or a couple different programs that they offer, then we create records in the program table for those data to go in. And then we make sure that we understand how a session would work within each of that program, so that each time somebody participates in that program, we log that in the session table. We also have to go through a process of understanding how they collect individual information. They build out a demographics table, which contains all of that individual information. And so we figure out how that's populated and again, like how we can get as much information about those individuals as possible into those different data tables. Does that, please jump in and let me know if there's something like even more specific that I could talk about.
Thank you. And I do
Sorry, this is Evelyn. Can I just add, sorry, question that. So are you doing any mapping? So even if the CBO is defining the program based on how they define it, are you create a consistent way to understand the program types?
So right now we don't have it broken out into different program types. We just have every program as a unique type of program. But I think that that's a really important sort of next step as you get more and more programs, is to start to then break them into different categories and map them that way. So unless somebody else has done, like, I don't know if Ken or others wanted to talk more about that, but to my knowledge, we haven't gotten to the point where we're sort of breaking out patterns of programs yet, if that makes sense.
Yep, no, that's fine. Oh, sorry, go ahead.
Yeah. And this is Ray, one of the leads of the coding project on the CDC side. And I just want to say, just so everyone's aware, I did put a link to the coding data model. It's not quite the CORDS data model, because CORDS was around long before. So there's some nuances and differences. And if someone on the CORDS team wants to put your data model link in there, that would be great as well. But a lot of this, one of the questions was the standardization of the data. So it is, the process of mapping that data to the standard data model for Cody at CORDS in North Carolina. In Colorado. So that allows us to kind of do that mapping, the hard work of seeing, how we can standardize their data so that we can ask those longitudinal questions about their data.
Great, thank you. Wonderful. I do have another question from Irma. What is the role of consent of individuals whose data are being linked? If you don't mind chiming in about consent.
So I can answer part of this question. I might have to rely on others to jump in too, but my understanding is right now, the primary use cases are around research. And so we went through a typical IRB process for all of these data. And so we have, I think, we have the process of not having to actually get consent from each individual. So the typical waiver that was approved by IRB, and public health surveillance often fits under that same realm of a consent waiver. But as different use cases get built out, I think that consent piece is important. Again, not only just from a technical IRB perspective, but also making sure that clients of organizations might be aware of that kind of data sharing, or that organizations are sort of thinking through whether this is a good use of their client data. Does that help address the question, or Ray, do you have any other components of that?
Yeah, no, I think that's exactly right. I will expand. In North Carolina, we've added some additional community partners in the YMCA, Parks and Recreation, and others. And so in addition to doing everything that Emily described, we went to took an extra step of meeting with the county I guess, the county board, and really presented Cody. They had their lawyers involved just to make sure they also felt comfortable, even though we have the IRB and stuff, because as you're starting to engage, data from the county, both in Raleigh and Durham Parks and Recreation, they wanted to also ensure that their lawyers agreed that it could be shared, and/or did they need to notify the members of their programs. In the end, they felt that they did not need, it didn't require notification, that it fit within their mandate to share that data as long as it was de-identified and anonymized.
Thanks, Ray.
One additional comment, Emily. This is Ken Scott. I was involved in some of this work earlier, and now I'm at NIOSH. But the one thing I'll add to Emily's comments and Ray's comments is that data governance for the Cody at Courts project is kind of a different presentation all of its own. But there was a lot of work that went into establishing the IRB, as well as data sharing, different types of data sharing agreements between the different organizations to support the data exchange and analysis.
And I'll put a link to the description of the Cody governance in Colorado in the chat. So.
Thank you. I do have some additional questions. Great input from participants today. So there are two questions from Elisa. So what data platform / IPI is being used to synthesize data?
What data platform? I'm not sure. Ken, Ray, do you know specific? I think so like beyond just developing our virtual data warehouses in the common data model. I want to make sure I understand that question correctly.
And Elisa, if you are able to chime in, please feel free.
Thank you so much, Emily. You mentioned tables, like where do those tables live? And I may be being super literal, but I'm just curious, like you're getting all this input from that beautiful circle. So where is it being synthesized? Like what program? Or
right.
What are you working?
Okay, so let me know if this answers your question. But so all of those tables are built. So we developed the common data model, and then all of those tables are actually housed within each organization in their own virtual data warehouse. So there's no sort of common repository for all of those data, which means that anytime we want to create, say, a new table or new update or send out a query, we have to do that in a kind of decentralized way. That's part of the CORD's federated model, because we want to make sure that each data partner has total autonomy over their data and can decide when it's being used and can sort of opt in or opt out to different kinds of participation in queries. So does that sort of answer your question about like where that's stored and how that's developed?
Yes, thank you so much.
And so we have a lot of documentation around how that happens.
Yeah,
so if you're interested in that, we can definitely share it. Like, here's how we implemented our data model, and here's, here's how we build out these virtual data warehouses, and here are the specifications, et cetera.
That would be amazing. Thank you so much.
Yeah, and just to add, so CORDS and Cody writ large, I mean, they function as a clinical community distributed data network, so that the partners or data owners house their data. For the most part, there are some groups, especially where Denver Public Health and then in North Carolina, the University of North Carolina house the data for partners that don't have the infrastructure to house the data model, the data. But then they submit queries of the data. So as Emily said, it doesn't, sit in a central repository. The data is queried using the vocabulary of the standard data model across all those organizations, if that helps. So there isn't a platform per se.
Thanks, Ray.
Thank you. I know we're coming close to time, so I'll chime in two questions. And then I think if any ones that are left, we can work, Emily, offline to kind of answer them and share them back with the team via email with the entire work group. So one follow-up, which I thought it would be really interesting to answer, is about what are the most significant positive outcomes for each of the different stakeholders involved in the project, health systems, CBOs, and ultimately, and importantly, patients and clients?
I think that's a really great question. And I can give my sort of best understanding, but of course we would have to talk to each of those individuals to get a sort of comprehensive look at how they would define what's most positive for them. But some of what we've heard is that, you know, these partnerships are really multifaceted. I mean, what we talked about in the last work group meeting is that, you know, public health often functions in that very upstream space, which is really important, but also sometimes hard to understand how what you're contributing is actually working towards the public good. And I think that things like COVID and some of these other sort of social needs crises that we've experienced are good examples of how public health can address and participate in this kind of work. And so I know that, like, for example, around COVID, a lot of the CORDS partners felt really like the partnerships that they were a part of and being able to participate and contribute data to the network was really meaningful for important public health use cases. It also gives people this sense of a broader community. I mean, these are organizations that share patients, that share clients, that are trying to work together, not just in public health, but in all sorts of ways. And so giving a really centralized goal around developing these research or public health use cases, it then spreads out and it gives people, you know, other benefits of just being able to know other people at these organizations and develop partnerships in other ways. And so I think that, you know, so I don't know what each organization would say as the biggest thing for them, but I think that that partnership piece is a big part of it. And knowing that they're contributing to answering public health questions that we really can't answer very well using other data sources is another huge benefit for a lot of groups. But Ken, Ray, you might have other thoughts too.
Dylan, I was reading Jorge's question, I'm trying to digest it, so I apologize. But I will say, Jorge, I'm happy to answer your question. It probably have to take it offline. It's a lengthy one, but lots of answers there. Ken, any more comments in addition to what Emily was saying?
No, nothing from my end. That was a great response, Emily.
Wonderful. So thank you all for the engagement. I know we're a little over our presentation. We want to ensure that we keep on track with the upcoming agenda items. So if we do have time at the end, we can circle back to the questions, if that's okay, Emily, Ray, and Ken. Hopefully we get to answer all of them, but if not, we'll follow up via email with answers to those that are pending. We're keeping track in the background. So thank you, Emily, so much for your time. It's really a pleasure to learn, and we appreciate your partnership with us.
Thank you. It's great to be with you.
Perfect. And Kate, I think, yeah, we have you next.
Great. Fantastic. Can you hear me okay?
Yes, we can.
Great. Fantastic. So thank you very much, everyone. Great presentation. I'm from Colorado, and I always love hearing about Cody. I always pick up a few more pieces of information every time I hear about it. So this next conversation we're going to go through is to give you an update on the comments received around the public health business case. And what we're going to do is we'll walk through about 25 people, individuals submitted comments via SurveyMonkey. We want to really thank everyone for their feedback. The purpose of this feedback was to ensure that we updated the business case with the correct information and understanding what are some additional details that we wanted to put in describing the value proposition of the initiative and the initiative goals and the schedule and any potential benefits, assumptions and risks, as well as the return on investment. So you can see from this slide, from the different sections of the business case, the number of comments and feedback that we got from the 25 individuals that sent in feedback. What we're able to do with that, next slide, and we'll walk through this in a second, but we wanted to also make sure that folks were familiar with the scope. We'll go through, we wanted to confirm that what is in scope and out of scope for this particular use case work group. And then we'll go through the different findings of and the general findings from the comments and feedback and how they are going to be addressed, either updated in the business case or going to be discussed throughout the work group. So from this slide, you can see numerous feedback. The public health business need got the most feedback with a lot of great insight on the business need for doing standardized data collection for social determinants of health for public health uses. We'll go ahead and go to the next slide, please. Great. Oh wait, back up one slide. I didn't do the out of scope. So one thing we wanted to point out, there was a lot of fantastic suggestions within the feedback. And there was a few things that we wanted to emphasize around what was in scope and out of scope. So with that, the group is focusing on public health use cases for chronic disease and disease prevention. And also it's within the project charter that we're going to be using a consensus-based approach around this. But we wanted to make sure that within this group, we are not going to be defining any data exchange standards or data elements for race, ethnicity, sex, primary language, disability, sexual orientation, and SDOH domains, so big specific domains. There's other groups that are doing a lot of that work, and we will absolutely stay informed and stay aligned, but this group will not be teasing out those specific details. We also will not be creating any use cases that directly do not support public health data activities, as it's stated within the project charter, so people will have access to that on the Confluent site. And then also, we are not going to be developing any implementation guides, FHIR implementation guides, or any of the resources around the FHIR implementation guides. We'll get to some more details on how these things line up in just a moment, but we wanted to make sure of in scope, out of scope. There's a lot of great suggestions of don't forget to do this, but there are a lot of those things as they are going to come up in our conversations. We will make sure to jot them down to the parking lot, but we want to make sure, and we'll always reference back to what's in scope and out of scope for this particular use case. Next slide, please. All right, so from the feedback received to date, there's a couple of different things. These are some of the general themes that bubbled up to the top. And on the left side are the general themes and then our initial response. So we had some great feedback around referencing tribal nations more explicitly and ensuring that tribal leadership is participating within the work group. So we will incorporate those additional details in the business case. And the CDC project team is also leading outreach to different leaders who are coordinating different activities with tribal nation leadership. So there's definitely some additional outreach and connection that is going to occur with this. There's also was a lot of great feedback around recommendations and participation for local public health agencies, epidemiologists, subject matter experts. And so what we want to also explore and implore you all to do is there's outreach by the project team, but then work group members, if you know of a particular group or person that would be very beneficial in listening in and contributing their expertise to this, send them the information, allow them to sign up for the work group, become a committed member. But we ask the work group members to also spread the word around this work group as well. So absolutely great suggestions out there. The third one is around further clarify the impact around data silos in the business need and the business silos for public health and addressing priorities and population health and measurement. And we absolutely recognize that the problem with the persistent data silos in the ecosystems at a local and a state and a national level are absolutely an impact. We are going to be able to discuss this in future work group meetings and include in the use case development of what are some of the details and how those data silos are impacting the use case as it's going to be developing. So we're going to put a pin in that, but we will be discussing that in future work group meetings. The next one speaks to requesting more specificity regarding data details, such as data type collected, data level, maybe individual level, population level, and then whether or not this use case will exclude survey, sample, or representative data. There's a lot of comments about the different types of detailing out those, and we acknowledge that, but we want to also double check that we are going to be discussing that in the future work group meetings as we get into those details for the use case. So put a pin in that one as well, that the level of detail of data and what is available and feasible to be collected is going to be very important in the use case development. The next one, there was a few things around defining chronic disease. Some of them, some questions focused on chronic physical disease versus mental health versus preventable. And so what we want to do is we'll incorporate this, the additional details in the business case. We'll also incorporate some links to NCCDPHP's specific definitions around chronic disease and ensure that that scope is defined in the business case as well as the use case, to make sure that everyone is on the same page with that. With the chronic disease, since NCCDPHP is the sponsor of this program, and also it's chronic disease is such a huge indicator for health and well-being across the nation. It's going to be important to make sure that we're all lined up on what do we mean by chronic disease, how are we speaking to it the same way, and then how is that going to be focused on within the use case. Lastly, there was also quite a few comments around the downstream impact of COVID-19, the public health emergency, the current economic crisis, and how that is impacting individuals and communities. And so we are going to be incorporating additional language into the business case on the public health emergency and its emphasis on how it's impacting the social, behavioral, and environmental factors of health. So those are great suggestions. And then finally, there were some different questions and feedback around the alignment with other CDC and HHS data initiatives. Got a lot of great suggestions in there around CMS and CDC initiatives. And then we will be discussing this as we go through the work group meetings. The next two slides are also, we've identified some of those different efforts that you all suggested, and we wanted to just clarify where some of them are focusing and where there's an opportunity for alignment for this, the SDOH use case work group, and to contribute or align and collaborate or complement those different efforts, and to make sure that all of these different efforts are lining up. I'm going to stop there and ask Sheetal, Amy, Evelyn, if there's anything else we want to add around the feedback received to date for the current business case.
No, Kate, thanks. I think you covered it. Thank you.
Yep, agree.
Great. Now, I've been speaking and look at my notes, and I think that there's been quite a bit of chat activity. So I want to double check, Gabby, do we have time to make sure that we address anything in the chat or any comments or questions that might be pressing?
Hey, not direct questions. We're just kind of closing the loop on some of the earlier feedback on the coding presentation. Yep.
Great. Fantastic. All right, so those are some of the general things. Thank you very much for contributing to the survey. That's you have some great, really good content feedback. So we really appreciate that, and we'll be incorporating that into the business case. All right, next slide, please. What we do want to speak to is some other related initiatives. It did come up in the feedback and also in some of the conversation in the kickoff meeting. Is what about Helios? What about USCDI Plus? And we wanted to just kind of organize and acknowledge that these activities are very important into the ecosystem around data and the needs for standardized data. But it's probably good to kind of make sure that folks are on the same page of what are the focus of those particular efforts and initiatives, and where there's some opportunity for alignment for the CDC public health use case work group that we're in now. So the first one just speaks to Helios and a summary of what Helios is focusing on. The focus area around Helios is around data exchange standards. They're focusing on FHIR implementation guides and building blocks for public health. We think that there's an opportunity for use cases developed by this group can help further refine and implement through the Helios initiative, potentially. This use case is going to be kind of architecture agnostic, since there's quite a few different architectures out there that could be implemented, but it's not going to be particularly designed for one particular solution, but there's an opportunity for alignment across these. The next one that was also recognized was MCode. MCode, if folks aren't aware, is a non-proprietary open source structured data element for oncology. It's actually minimal recommended standards for structure and content for health record information. And this is focusing around data classes, elements, and a data model for oncology. So very specific area for these data elements, but we think there is an opportunity around MCode, utilizing the use case and the details from this project to help identify potential related social determinants of health data elements for aggregation or to support any of the cancer activities that are happening. The third that's on the slide is around USCDI Plus. USCDI Plus is a new initiative with ONC that is supporting extending what they're doing with USCDI, the core data for interoperability. And the USCDI Plus is prioritizing at the time around federal partners and harmonizing and advancing the use of interoperable data sets beyond the core data in USCDI to meet different agency programmatic requirements. So this is going to be around data classes, data elements, data model, and there's an opportunity to inform which relevant SDOH data elements and classes could be included in the EHR data to support CDC and other federal agencies. This group's going to focus more on the data standards, data in the use case to support public health uses. There is some alignment there, but we want to make sure that it's not instead of or contradicting. It's going to be complementing the work. Next slide, please. All right, this one just goes through and talks to MEN's decentralized data architecture, focusing on data extraction, normalization, aggregation, data queries, data visualization, and analytics. But it's a way for health departments to use a decentralized surveillance system using EHR data for different chronic disease risk measures at national and local levels. And there's a great opportunity here around using some of the relevant workflows and SDOH related data elements developed in this project, and it might be able to complement what MENS is able to do with their data elements and potentially add to that. So I think that there's absolutely an alignment point there. We just heard about Cody, which was a great presentation. I think that we've identified that Cody potentially could align with this use case around the common data models, and in case there's additional ways to expand different data elements for collection and access by their distributed network. And then finally, there's Medmor, which is another excellent effort that's happening at CDC around gathering EHR data for multiple public health and research scenarios. They've developed a reference architecture and reducing the burden of healthcare providers to help provide standards and methods to send data from EHRs for a variety of public health and research purposes. This is a data exchange architecture. They have a focus around FHIR, but we think that there's an opportunity that they can utilize these relevant workflows and SDOH related data elements that are going to be developed through this use case work group. So hopefully that is helpful to see how they're lining up, but some of these are a little bit different. We want to make sure that there's a complement and there's a connection and coordination across all these different efforts. I am going to pause there. Amy and Sheetal, anything else to add or anything from NCCDPHP team that you want to add into this? And of course, this is not a complete list of initiatives, but these are some of the ones that did come back in the feedback.
I think you covered it well, Kate. Thank you.
Right, fantastic. I'm going to pass it back to Gabby. I think we're going to do some live feedback and questions and answers. Gabby?
Yes, thank you so much, Kate. That was a wonderful overview. And again, really echoing the gratitude on the comments received, specifically around the business case that we're just mentioning. If you didn't have an opportunity to submit your comments or feedback via the SurveyMonkey, as mentioned, we would like to leverage this opportunity, give folks a few minutes to react to some of the feedback received, but also share any thoughts that maybe you wanted to submit but didn't get a chance to. We are open to people, kind of going into the reaction box and raising their hand, or if you like to chime in via the chat, we also welcome that. So we'll give people a few seconds. And as people are kind of thinking through this, we are incorporating the feedback received. Kate just went over it, and we'll be posting a revised version for voting, which we're going to cover next. So I'm not hearing anything in the chat. Okay, sounds like we have good agreement. Let's see. Okay. And I'll put the link in the chat as well, unless, we're gonna walk through it. I know we wanted to go over the consensus voting process, which is the next step. So we have time. I'll be happy to pull up the business case, right after that process. Evelyn, I think you'll be next.
Okay, great. Thank you, everyone. And good afternoon. So as this will be a new process, I'm just going to walk through how we need to achieve consensus as a work group. So a recap of the levels of participation. So those joining us today, you've been invited to formally join the initiative either as a committed member or an other interested party. And each one of these has specific roles and responsibilities. So as a recap, as a committed member, you are expected to participate in biweekly meetings and actively contribute to the development of the deliverables. I do want to specify, this does not mean you have to be here live for every meeting. It just means that you're following the project. You if you can't join in person or live, you review the recording or you look at the materials. So it's just a way to ensure that you have been following the process and therefore feel you're able to submit a vote for an artifact or deliverable. Other interested party means you want to be still, you want to monitor it, but you don't feel, there may be times where you may not feel you can report on or vote on it. But again, you also, like vote, you can submit your comments. So we do still welcome and incorporate comments from both committed and non-committed members. Next slide. So what about our process? So we had talked to introduce this process last week, 2 weeks ago when we went through our consensus voting process, but acknowledging, again, this project, our work group, is being initiated under Health Level 7, HL7, that is an ANSI accredited organization. So our consensus process really builds on how HL7 gathers feedback from their members. The only difference is HL7 does require all their members to be paid members, and we are not doing that, but we are following their process of allowing having at least a group of members as committed to cast a vote. So our process is that each committed member will be given at least 1 week to vote on a work group deliverable and submit their relevant comments as we'll walk through the SurveyMonkey questions. You will have all no votes. So if you do, you have 3 ways. We'll go through the different ways that you can vote, but any no vote or formal objection and yes with comments will be resolved. So that is part of the process. And again, only committed members can vote on deliverables. Next slide. So why do we follow this consensus voting process? I like to reference this image you see here on the right-hand side. So consensus relies on due process to allow equity and fairness. So really, again, it's just ensuring that everyone who participates has an active voice, right? And this is, what supports us being a public, open, transparent work group, very much aligned, like the Gravity Project and our other HL7 projects. The consensus process supports open participation, a balance of interest, and equal opportunity for all participants. And the voting process provides an opportunity to address all views and resolve any objections. So this is important. Again, if you vote no as a formal objection or yes with comments, we will respond. You will have a disposition. Next slide. Okay, so during the process, when we open it up, consensus members will vote on the deliverable, as I mentioned before, only committed members, and then other interested parties. So I mentioned this at the front. What's important here is just to acknowledge that for us to reach consensus, so it's not like every committed member, if we have 100 committed members, we need 100 votes from committed members. We need at least 60%. Again, this follows the HL7 process of having at least 60% of members that sign up to vote on an artifact to pass it. Next slide. So our process instructions, and you'll see this on the survey. You have 1 week and you could vote one of 4 ways. You can vote with a yes, where you're just acknowledging. You can vote yes with a comment. It could even be a positive comment, or it could be a request for a change. you have that opportunity. You can vote as a formal objection. Any formal objection must have a comment associated. So if you just do a formal objection, if you have nothing to say, we'll come back and say, we need a comment. You are also able as a committed member to abstain, and that still counts, right? It still counts as the overall. If we have 60%, it still counts even if you come back as abstain, where you do not want to, you decline to vote either yes with comment or formal objection, but you have an abstain. Next slide. So what is our timeline for voting? I mentioned you have a week. This just gives a recap of how we started since we initiated our work group. So we kicked off April 20th. We introduced the consensus process and the business case. We are meeting, and then we had a deadline given as homework for public comments to be received by early this week. We are reviewing it today, May 4th. And that was why we also opened it up for public comment during the live call. And then now we will then publish. So based on any input we are getting today from the chat, and I'll pause again to see if there's any other further input, we will then consolidate that information and publish the document for voting. So we will either publish on Friday by end of business, or publish Monday, depending if we get any additional comments today. But the goal is to publish it as soon as possible, and then you will be given a week. And then our objective is to publish the consensus voted business case by May 18th. So I'll pause there if there are any questions.
Evelyn, I just want to go back. Sarah had a comment under the business case around inclusive definitions, creation of SDOH measures. Sarah, could you elaborate on that a little bit more of what you were looking to see more in the business case around that, if you're willing?
Hi, sure. I actually think somebody brought this up at our first meeting, and I was assuming that person was going to submit it in their written comments, but possibly they didn't. And I think there was a point about making sure that the way we're measuring SDOH is informed by what communities view as social determinants, and that we're not just like in an academic way deciding for them what's being measured. I'm doing a terrible paraphrase of whoever made this comment last time. Maybe you can go back to that previous meeting recording and see that comment, but I'm pretty sure somebody made a comment like that.
Great, thank you very much. We'll do that. Anyone else wanted to add in? Or if anyone was here and had that comment last time, please clarify.
This is Commissioner Encarnacion. I just wanted to add to that comment. I think that it's important for no matter where you are, your social determinants will be a little different based on geographic location, as well as access to care that you are offered or you have. So I just wanted to support that comment that was made. Thank you.
Thank you.
Okay, I don't see any other comments just yet. So I think it'll be good to maybe walk us through. We have 5 minutes or so left, and review our next steps and kind of navigate where you can find our resources. So I'll go ahead and actually do the resource navigation first, and then navigate kind of the SurveyMonkey for voting. So our Confluence page is shared in the link there in the chat, and I'll put on my video just to ensure that we see each other virtually. So all of our information is here. When you go into our project charter, and please, if there's any technical issues accessing our work group Confluence site, please let us know. You can email myself or Savannah will be able to troubleshoot with you, but it gives you an overview. The project charter documents housed within our documents page. It's linked to the home page, and you can see here our timeline, our project charter, as well as the proposed use case that was used for comments. So the sections that were reviewed, it gives you the version history. Here's when we'll add that work group members have added input, and we revised it for consensus voting. So that will be the 3.0 version that will be utilized for the consensus voting process that was just mentioned. And it gives you an overview. You can download this document. You can see it here in your window. Again, really, please let us know if you're having access issues so we can attend to those immediately. And again, gives you just an overview of what we're doing as part of the project. And this is our why. Why is there a need to establish a use case that can support public health efforts and decision making for that future state? So we are very grateful for your participation and want to ensure that you know how to access those links. So again, via our homepage here, you also get to see our agenda, meeting information, how to join the call, homework, and all the relevant documents are here in our slide deck, as well as our recordings will be posted within 2 business days for everyone's review. So you can see that there. I'm going to navigate rather quickly a little bit about our consensus voting instructions. So as mentioned, you'll get to see committee members will receive this form to complete via SurveyMonkey. Feel free to scan it, but we're gonna email you. If you signed up as a committee member, we're able to see on Confluence, and we have a report that we clean up and monitor very often, 2 to 3 times a week, to ensure that we have captured the right audience. If you would like to update your membership from a interested party to committee member, please email me directly. I'll be very happy to support you. I'm gonna drop my email in the chat if you want to double check your status. We really encourage you to contact us directly. What that process will look like is, as you can see here, the SurveyMonkey, it's really giving you an overview of, welcoming, very short description of the voting. The voting period, as mentioned, is there, instructions, and if you have questions, our contact information is also listed on SurveyMonkey. From there, we will ask you to please identify yourself to ensure that we cross-check with our workgroup listserv. So for purposes of testing, I'm just going to right here, tests, and kind of preview what the survey will take. It estimates that it will take 2 minutes to complete. We want to ensure that we identify the partner type in terms of voting, so we can provide some of that qualitative information back to all of you when we report on the 18th. So you select the type of partner that best describes you, and if these categories do not fit your organization, you can select other and let us know. You will click next and then cast your vote. So one option, it is required, as you can see here. So you will select one option, and please make sure that you click done at the end so your vote can be recorded. Once that will be the conclusion of our voting process. So again, this is really our homework for all of you to read the revised public health business case. Committee members will receive the link to vote directly. As you can see here is CDC SDOH business case, and we will commend you to please reach out if you would like to update your membership status, and you have our contact information as well at the end of this slides. We are at the top of the hour, so we'll just like to thank you for your participation. We had a packed agenda, I think less than 30 seconds left. So if you have any final thoughts, questions, we welcome those. Thank you for your patience. We want to ensure that we attend to those questions, and Ray did a wonderful job with Emily answering them in the chat. All right. So thank you all for your time. This will conclude our second meeting, and we look forward to reconnecting on May 18th. talk to you soon.
Thanks, everyone.